Hello, my name is Ihab Atala, and I'm an Associate Professor of Medicine at the Medical College of Wisconsin. Today we will be talking about treatment-free remission and Nilotinib. The reason we are specifically discussing Nilotinib and treatment-free remission is that treatment-free remission was recently added to the Nilotinib label. The Nilotinib label recommends considering treatment discontinuation for two patient populations. First population is newly diagnosed adult patients with CML in chronic phase who have received Tasigna for at least 3 years and have achieved a sustained molecular response, which is a level less than 0.0032% for at least 1 year. The second population is patients who have been previously resistant or intolerant to Imatinib and who have been on Nilotinib for at least 3 years and again have achieved a sustained deep molecular response for at least 1 year. These recommendations have been based on multiple studies performed with Nilotinib, mainly the ENESTfreedom and the ENESTstop. So listed here are some of the studies that have studied Nilotinib discontinuation in patients with CML in chronic phase. Each of those studies is slightly different. So for example, in the ENEST goal, patients would have been on Imatinib therapy but have not achieved MR 4.5. but have achieved MMR. In the ENEST path, patients need to have been on Imatinib for at least 2 years, have achieved a complete cytogenetic remission, but not MR4. ENESTfreedom was in newly diagnosed patients, and ENESTstop, patients had to be on Imatinib for at least 4 weeks, and then were switched to Nilotinib either because they were resistant, intolerant, or physician choice, but also have not achieved MR 4.5. A study which included all TKIs is the last study, and these are patients who were on Imatinib, Dasatinib, Bosutinib, or Nilotinib, have achieved a sustained deep molecular response, were intolerant to any prior TKIs, but not resistant to any prior TKIs. In the next few slides, I will discuss in more detail the ENESTfreedom and the ENESTstop, which have been the basis for the addition of treatment-free remission in the Nilotinib label. The enrollment criteria for the ENESTfreedom were patients who were in CML in chronic phase, were on treatment for at least 2 years of frontline treatment with Nilotinib, and have achieved an MR 4.5 at the time of enrollment. After enrollment, patients were monitored for another year, which that 1 year was called a consolidation phase. If the patients maintained a deep molecular response with no assessment worse than MR4, then the patients entered the TFR phase. Patients would restart their drug if they lose MMR. Very similar to other stopping studies, the treatment-free survival was about 50% in that study. The ENESTstop was slightly different. That study included patients who had been on Imatinib for at least 4 weeks, and then they were switched to Nilotinib either for intolerance, resistant, or physician choice. After that, patients received Nilotinib consolidation phase for 52 weeks or 1 year. And if there was no loss of MR 4.5, then patients entered the TFR phase. Patients were monitored every 4 weeks for the first year, every 6 weeks for the second year, and thereafter every 12 weeks. 163 patients were enrolled. Of those, 126 patients maintained that deep molecular response and entered the TFR phase. Patients in total had been on a TKI therapy for an average or median of 87.7 months and on Nilotinib for 53 months. 40% of patients switched from Imatinib to Nilotinib for intolerance, 24% switched for resistance, and 36% was for physician preference. This study demonstrated that for patients who were resistant to Imatinib and then switched to Nilotinib, that the rate of treatment-free remission for those who were in a sustained deep molecular response was similar to the other patients who switched from Imatinib to Nilotinib because of intolerance or physician preference, leading to the consideration of discontinuation of second-line TKI such as Nilotinib in patients who were previously resistant to their first-line treatment. In the paper, they detailed very nicely the cardiovascular events seen during the consolidation phase. 6 patients had a cardiovascular complication, most of them either resolved or resolving. The cardiovascular side effects included 2 cases of peripheral ischemia, 1 case of intermittent claudication, 1 case of peripheral arterial occlusive disease, 1 case of acute MI, and 1 case for coronary artery disease. In summary, nilotinib discontinuation can be considered in patients with CML chronic phase who have been on nilotinib for at least 3 years and have a sustained deep molecular response. Sustained deep molecular response is defined according to the nilotinib label of a level of MR 4.5 for at least 1 year. Proper monitoring is really important after discontinuation, and patients need to be monitored monthly for the first year, every 6 to 8 weeks for the second year, and every 3 months thereafter. The rate of successful TFR with nilotinib appears to be similar to other TKIs, and the ENEST-STOP study demonstrated that switching from Imatinib to nilotinib for patients who were resistant to Imatinib could lead to successful treatment-free remission down the line. And finally, a multi-team approach is a key component to the success and safety of TFR. Thank you for listening to this presentation.